my talk today is on glaucoma and where we are going. I'm a glaucoma specialist. I'm trained in both cornea and glaucoma. I do everything anterior segment. There's nothing that I don't do in the anterior segment. You throw me anything in cornea to glaucoma to complex cataracts, reconstructive surgeries, I do it all. Every time I come, the mouth goes right, I apologize. So here's a timeline for glaucoma. Do you know who invented glaucoma surgery? Yeah. So this is the guy, Albert von Grafe. He practiced in Austria, Germany, in that area between Austria and Germany, and he had a big practice in Berlin. And he actually was a remarkable person. If you read his history, he died at the age of 42 from TB. I also had TB. That's my only connection with him. Other than that, he really invented. How many people use the one Grafe blade? You did it? Did you use the one Grafe blade? No, no one other than me and Venkatesh. We're the old people. It's one of the best designed blades ever. You know, in eye camps that I attended in out of Sarojini Devi, I did like 25 eye camps. I really enjoyed every one of them. I used to go like 3 days before, used to come back 4 days later. A beautiful experience. All these people with white cataracts used to take me exactly 1 minute to slice open the incision from temporal to nasal side with the one Grafe blade and take the cataract out. It was intracapsular cataract extraction with the cryo, and then yank it out and then put 2 sutures. You're done. And day 5 after the cataract surgery, you give them standard 13 diopter glasses. That used to be the way. Till your guy here, Dr. Venkataswamy, changed the model to base camp. And then the eye camps actually became standard of care. I mean, in the sense that the modern technology, modern care came to eye camps. So you identify the disease in the villages, bring them to the base camp, do the surgery, take them out. Juan Grafe was the one. A lot of people used to track from all over Europe with painful blind eyes, used to go to him. He used his Juan Grafe blade, and some of them, the pain went away. In some, it did not. Do you know why? In those people where the pain went away, they were suffering with acute angle closure, the modeled into chronic angle closure, became a painful blind eye, the attack resolved. But then those with open angle glaucomas, with super high pressures, the attack did not. But in 1850s, the knowledge between that there are 2 kinds of glaucoma was not existing, right? So there was open angle glaucoma, closed angle glaucoma. That knowledge came around 1900s. So he was 50 years ahead of his time, but he discovered the first treatment known to mankind, iridotomy, through his blade. Even today, I do 4-dot iridotomy using a 30-gauge needle at my slit lamp in the clinic. Cost me exactly 2 cents to get that 30-gauge needle. And if somebody comes with the Iris Bombay, I don't have the energy to walk all the way down to the YAG laser. I make them sit at the slit lamp, and 2 seconds later, attack is over. 30-gauge needle into the eye. Every acute angle closure glaucoma for the last 20 years that I've treated, same procedure. They're at the slit lamp, betadine prep, some lidocaine drops, 30-gauge needle, and the attack is over. Once the pain is gone, the patient will do whatever you want him to do, or her. So here is how I do my trabeculectomy is the 5-stage. Do you guys follow Devgan's cataract coach? Okay, so you may have seen my videos, may not have. Uday is a good friend, and last year, 2 years ago, he asked me to start building up glaucoma videos for him. So every month I committed myself to send one of my anterior segment videos. So if you want to see a lot of these videos, you can go to Cataract Coach, punch my name in, and then every month I post some of these videos. And the main problem here, what is the problem? It doesn't matter how you do this trabeculectomy operation, right? You're diverting the aqueous through this flap, through the sclerotomy or keratectomy into the subconjunctival space. But these operations fail. No matter who does it, no matter how fancy you are, the end of the day, fibrosis is the king. That's the reason why these surgeries fail, because excess fibrosis in the process of wound healing will prevent aqueous from coming back in subconjunctival space. And therein lies your problem. Express mini shunt. I don't know if anybody here have used it. And those of you who have not used it, that's a good thing because that was the a device that was begging for a question as to where to use it. It's the same trabeculectomy operation, except instead of doing your sclerectomy, you're uh, you're inserting the uh, device to divert the aqueous into subconjunctival space, and you can see how the device is implanted. And the reason why I want you to pay attention is that you can better design these kind of implants. In 2003, they initially, when they introduced this device, they wanted the conjunctiva to be lifted and the device to be implanted straight into the anterior chamber. It resulted in a whole bunch of patients with flat chambers, choroidal effusions, and the device itself was exposed, eroded through the conjunctiva. I was, we were the first group to publish a whole series of complications because of which they changed the technique into a scleral flap and implantation under the scleral flap. And so you can see how to take it out through the conjunctival incision or through the anterior chamber. And then came along in 2016, the Zen gel stent. Do we use Zen here in India? Um, Good. Don't need it. so so it's a 40 micron, 43 micron opening gel stent that diverts. Beautiful technology. Don't get me wrong. It really in 3 minutes you're in and out. You can see the video on the right where it's going through the eye. And here is the subconjunctival approach where you pull the eye down and then I'm entering with the needle and at about 2 millimeters posterior limbus, you go through the sclera and drop it into the antechamber. So 1 millimeter of it is in the antechamber. The rest of the 4 to 6 millimeters is outside in the subconjunctival space. But, you know, human fibroblasts make no distinction between a gel stent, an express shunt, or a trabeculectomy, especially if you have a 43 micron hole that is draining the fluid out. What do you think the fibroblasts? How many fibroblasts do you need to close a 43 micron? Probably one or two. That's what happens. We were, again, I was unfortunate enough to have presented the, the first data comparing gel. This is not company-sponsored data, comparing gel stent with the trabeculectomy. And as I showed there, almost 70% of patients with gel stent started failing at exactly 1 month after surgery. In the long term, they were similar, but the gel stent people had more drops, and they also needed a lot more needlings to be done. So is it worth spending $1,000 extra on top of your the trabeculectomy? The cost of doing trabeculectomy operation, I priced it out, was $90. If you count the cost of only reusable or disposable instruments like a tenonylon, mitomycin, and that kind of stuff. $90, you can do your trabeculectomy. Here, for the same result, you are spending out a lot more money. So the gap here is fibrosis is the king. No matter you do the Ahmed valve, no matter whether you do the auto device that you have here, the Barwald equivalent, it does not matter. Anytime you divert the aqueous subconjunctival space, the reason why all these surgeries fail is fibrosis. So what we need is a slow release antifibrotic system. One-time application of mitomycin in majority of the patients does not work. Either it's too toxic, you end up with avascular cystic sepsis, a ticking time bomb with endophthalmitis, or it fails. And very few patients fall into the middle where they're happy. There's a good-looking blob, which is thick, and tenons is functioning like with holes in it in the sense it can percolate across. So what we've been working on, and right now it's with FDA, is a slow release PLGA 10 micron, 10 to 14 micron wafer that you place at the end of your surgery. All you need to do is put it in a subconjunctiva before you close the conjunctiva, and on exposure to aqueous, it releases mitomycin in the first 48 hours and 5FU for the next 3 weeks. And you can see how this is mitomycin alone. You can see it's thin-walled. This is after using the eluti glass I called it a luti glass. You can see how the tenons is intact, but it's porous honeycomb tenons. That's what you want. You want the intact tenons, but you want the tenons to become honeycomb, and that way it can percolate the aqueous in subconjunctival space, and from there get sucked out by the subconjunctival blood vessels. So, and one of you may come out with a much better solution than this, but this is the gap area that you need to resolve. This is the reason why a lot of glaucoma surgeries, like I always teach my fellows, all you need to do is 100 cases in the first year. Because every third year, 50% of them are going to come back for another surgery. And we have shortage of glaucoma specialists. We are yet to reach, perform surgeries on existing patients who need surgery. 50% are going to come back for another surgery in 3 years' time. When are we going to reach out to the masses out there that are going blind, right? It's a no-brainer that we need to do something better. Now, here is how I've been treating acute angle closure glaucoma. This guy, his cousin happens to be a ophthalmologist. She dilated him. He's a plus 13 diopter hypero. She dilated him for dilated full exam and put him in acute angle closure glaucoma. A week later, ended up in my clinic. And you can see all I did for him, lid speculum, betadine prep, some lidocaine, and then 30 gauge needle goes into the AC. And you watch the second video if it plays. I don't know why this video is not playing. I'm so sorry. So anyway, once you put the needle in, which is a close-up shot of what you're seeing there, within 10 seconds, 1 drop of aqueous is all that you need. Corneal edema goes down and the attack is over. Then you take the patient and do organless aortoplasty. Very underutilized technique, but very effective. When you don't need a special lens for this, you just shoot 400 to 500 micron spot size. I do it in multiples of 300 micron spot size, 300 milliwatts of power, and shoot it around the limbus till the iris withdraws, it shrinks and pulls it away from the angle, and the angle is open. And that's not the end of the treatment. A week or 2 weeks later, take the patient to the operating room, take the cataract up. And then don't wait for an attack to happen in the other eye. This is one occasion where you can actually resolve a damn glaucoma from happening, take the cataract out of the other eye, the lens, the other eye, and you're done. And it is, you need to train yourself to taking cataracts out of these narrow angles. Sometimes a lot of my cases, every month I get a patient with non-ophthalmos. So the chamber is almost non-existent in those patients. So I train myself using I don't do my cannular rexis using the utrata forceps because a lot of these eyes don't have enough room for you to introduce the utrata. So I do it with the cystotome. So if you want to be a glaucoma specialist, you need to train yourself because the regular cataract guy couldn't care less. He doesn't want to deal with these non-ophthalmic eyes or eyes with narrow angles or shallow chambers. They just want to make money by taking out cataracts that are non-existent to begin with, in the beginning. I should not say that way. But you know the idea, the general drift here. So if you want to be a glaucoma specialist, you want to train yourself to handle all the difficult cataracts because glaucoma specialists do get the most difficult cataracts. Combination of pressures of 60, shallow chambers, and a dense cataract sitting there. Now you get the picture, right? So 2 things that I want you to get from the trabeculectomy era. One is the fibrosis. How to tackle fibrosis, minimize fibrosis, and improve the success rate of all these surgeries that are coming in. It doesn't matter how you divert the aqueous into subconjunctival space. The end result is the same. Fibrosis is the king. So we have to develop something that is kind to the tissue at the same time enhances the success rate of the operations. Coming to the mix era. We all use mix here? Yes? Right. So it's a circular channel. Do you know this guy here? That's Frederick Schlem. He is the one who discovered Schlem's canal. Do you know in what year he discovered Schlem's canal? 1850s. Same time when Von Graffi was there, Frederick Schlem also lived, probably. and he also lived somewhere in Germany, Austria. Back then, if you want to practice anatomy and learn anatomy, the only way is to dig out dead bodies. And when you dig out dead bodies, the church used to go after these people who used to do that and put them in the asylum, in prison. And so Frederick Schlamm was caught, he was prosecuted, he was jailed, and fortunately for us, upon his release, the chairman of the Berlin Ophthalmology Department, who knew him before, took him in as faculty. And using the newly discovered microscope, I don't know how he discovered this 200 micron Schlemm's canal, that we call it Schlemm's canal now, back in that day and age with the tools that he had. Now that is dedication for you. So, always like to introduce the inventors. The word mix was coined by Ike Ahmed, famously. Malik Kahouk came along. You know, Malik was wanting to do research on the trabecular meshwork. So he went to his, in University of Colorado, he went to his bioengineers to design a blade so he can harvest it. And it hit upon him that he has got a device in his hand that can be actually used for clinical purposes. And New World Medical, that makes the Ahmed valve, took that patent and they developed the Kahoot blade, dual blade, which is very, very effective in a lot of patients. And then Richard Hill had this idea. He's also a glaucoma specialist in California. He had this idea of diverting the aqueous from the anterior chamber into the Schlemm's canal across the trabecular meshwork, which is non-functional. And so he had the idea of devising a little nut, and outcome was the glucose, the eye stent. And David Badawi, do we use other devices for canaloplasty here? No. David Badawi and his brother designed this very elegant system where you can inject, through a catheter, you can go 360 degrees and dilate the canal, at the same time do goniotomy. And they all work. And the point of the mix is that, you don't need to restrict mix only for mild, moderate cases. You can actually take care of advanced cases if you know how to do these cases. Here is a case with plateau iris syndrome, pressures were high, and that's his only eye. That's how glaucoma practices go. And here I'm doing goniosynechrolysis. Later on, I'll show you other ways of doing goniosynechrolysis. Here with the microforceps, I'm opening up the canal. And once the canal is opened up, you can see there are little bumps here and there. That's the ciliary processes that are turned up, narrowing the angle right in the plateau iris syndrome. So you go with ECP or endocyclophotocoagulation, shrink the ciliary processes in the process, and also it does two things. It opens up the angle and also controls the pressure. So doing the ECP now, what this video does not show, and what I do nowadays is to do like an Omni, which is what I said that Dr. Badawi has invented. So here is the Omni. So in these cases, all these cases, once with angle closure, I do goniosynechrolysis, and then I complete the procedure with goniotomy and viscodilation using one of these many devices that are there in the United States. And Hydrus is there. I don't like to do leave devices within the canal because of the risk of complications in the long term. So I don't do that much of Hydrus, which is the results are pretty good with the Hydrus. Here is your eye stent. Some of the videos didn't transfer when we are putting in, but at least you got the idea. You've seen these videos many, many times. Now, the gap in the mix at this point in time, the way I look at it is, I think everybody is either stretching the canal or doing goniotomy or a combination of both. There are multiple companies vying for the same spot, meaning the canal. It reminds me of early 2000 when prostaglandin analogs came into picture, and every company said their version of prostaglandin analog is superior, and they hired all these high-flying glaucoma specialists to fly all over the world, claiming that their company sponsored prostaglandin analog superior to the other one by 1 point or 2 points or whatever. It makes really no difference to the patient whether 1 point is less or high, right? I mean, really practically thinking, and that's the same time, that's where we are with the mixed procedures now. A lot of companies vying for your attention, and all they're doing is to divert the aqueous across into a Schlemm's canal. What we need is some slow release canal modifying agents. Just like LUT glass, I do have multiple patents on LUT glass and is going through FDA process right now. We're working on some things that hopefully will help modify the canal and beyond the canal. You want to inject something that will decrease the resistance in the canal and beyond the canal, thereby decreasing the episclerovenous system resistance and increasing the outflow. At that point in time, it doesn't matter which canal, which device that you use to stretch the canal, because the resistance is decreased, then hopefully you will get the pressure reduction into below 15. Right now, no matter, you can stand on your head, no matter what a technique that you use, a lot of these mixed procedures, you'll get pressures between 15 and 17 or 18. And some of them fail. They're like 20% of them don't respond at all. It's a great tool for patients with, if you're doing cataract surgery anyway, for patients who are on 1 or 2 drops. But advanced glaucomas, like I showed you, if you mix with something else, it will help you. I mean, a lot of my patients, they're all blood thinner, they're on blood thinners. Florida is full of old people ready to die or willing to or waiting to die. They're all on blood thinners, and they come with the advanced glaucomas. And if you do a regular trabeculectomy and leave the pressure at 10, a lot of them, they go and practice golf or they want to, and they will end up having suprachoroidal hemorrhage. So that means that I did my job, but then the patient lost vision with the suprachoroidal hemorrhage is not good. So this is lesson number 3. Wherever you end up practicing, know your patient population well, and then modify the techniques that you learn in Aravind to that patient population. Don't stay static ever in your entire career. If you are static, you're dead. You cannot practice the same medicine that you're learning in 2025 in 2050. You just cannot. But that's what a lot of doctors do, which is really unfortunate. I don't want you guys to do that. I want you to learn everything and think on your own. Don't listen to all these companies. Learn from them. I'm not telling you they're going to lie to you. They're in the business of selling. Doesn't mean you have to buy into it. You need to do what is good for your patients. Always think about one thing in life. Before suggesting a surgery to your patients, if you put your mother's face in front of you on top of the patient's face and say, hey, if this is my mother, would I do this procedure? And the answer is no, walk away from it. If the answer is yes, do the procedure. That's the right thing to do. So you know what? When you go home, you can sleep tight. A few rupees in the bank are truly will not make a difference to your lifestyle. We all are fortunate that we all are going to have very good lifestyle. Compared to majority of the world population, we are in the top 10, top 5% in the world population. So what are we worried about? I mean, you really want that amount of money that goes crazy. Even all the rich people don't use all that money. You should be in business, not in the business of medicine. You should be in doing real business, right? So anyway, my 2 cents on that. So this is another gap area. I'm working on something does not mean that you should not work on something. Who knows which one is better, right? This is another big gap area. I'm not going to discuss too much on the aqueous reduction. I don't like the ECP diode laser. Do we have ECP here? Good, because the pressure reduction from ECP does not last more than 1 year. So it's a temporizing measure. Because I have access to it, I use it, especially in plateau iris. Micropulse, I've never been super impressed with micropulse. I still use my old cyclocryo on patients with, end stage and people who are blind, etc. Except I'm guarded in the way that I use it. I do only like 5 spots in the inferior 180 degrees. And if the patient really has super high pressures, I repeat it only on 2 or 3 of the same spots and never touch the superior 180 degrees. And that way, you avoid all the complications that you read about in the history of cyclocryo, right? Like hypotony and calcium deposits and disfiguring eyes and severe pain, etc. With the technique that I use carefully, I almost always end up somewhere between 10 and 20 pressures. And so I still use cyclocryo and I do it freely in my clinic. Let's go to the glaucoma drainage devices. There's Maltino, George Borwick, Martin Ahmed. The first two came from South Africa. The last one came from India. So there has to be another Indian right next to it. And that could be one of you. There's always one of you that should come out from this institution that is going to invent something new, that is going to spread worldwide and make Arvind proud. Arvind itself is proud anyway, but it could be prouder if you invent, say, a new device. So Maltino famously, his professor, do you know the story about Maltino implant? You all need to take one lesson for today. Go back and read the history of all these inventors. With Google, it's a 2-second deal for you to read about, Anthony Maltino. Where was he? Where is he from? How did he end up discovering Maltino? His professor is Epstein. And Epstein designed steel tubes back in 1950s, 60s. That was the latest craze, the steel tubes. So he used the steel tube to divert the fluid from the anterior chamber and subcutaneous space. And within 3 months, every one of them failed. So as he's retiring, Epstein told Maltino, hey, if you place a little plate attached to it, maybe it will stay longer. So Maltino's initial 1968 invention was a large plate with this tiny tube that's placed into the antechamber, but the plate is right at the limbus. And every one of them failed because of erosion. And then he hit upon the idea of elongating the tube and making it into what we do now, 10 millimeter long tube, and followed by a plate. And George Borwick modified the plate with his enlarged the plate surface, which is what the Adi is based on. Martin Ahmed grew up in Lucknow, and during the Indian independence time, he was very young. He's a good friend of mine. That's why I know his story. He came to Hyderabad. That's my connection to him. Because of, I think there were riots going on in Lucknow, and his uncle brought him briefly to Hyderabad, and then they resettled in Delhi. And his dad wanted him to be a doctor. He wanted to be a bioengineer. So to satisfy his dad, he became a doctor. Soon after, he never practiced medicine. He did his bioengineering soon after that, and during the process, he realized that there is a need for this glaucoma drainage device modification. He designed his valve, and then he took that concept to Los Angeles, and like they say, the rest is history. The key findings of it doesn't matter what glaucoma drainage device you use, 30% failure rate, rule of 30s, 30% exhibit hypertensive phase. Do you know what hypertensive phase means? Residents? No. So when you place a plastic material in the body is not going to say, Dr. Ayyala, Dr. Venkatesh, you're so good, I'm going to listen to them. Okay. What does body do? Body does not want anything foreign in them. So it's going to throw in a lot of fibroblasts. And because it's about 8 to 10 millimeters away from the limbus, and most of the fibroblasts are near the limbus, it takes them about 7 to 14 days for the fibroblasts to migrate to where the plate is located. That's why you start developing this and this encapsulation that forms to the point that more aggressively in some patients than other patients will cause the pressure, the aqueous to be trapped underneath the encapsulation, prevents the aqueous from being absorbed by the subconjunctival blood vessels, and the pressure goes up to 30s, 40s, 50s. And typically it happens around day 30, give or take, this way, that way, 1 month. And so that's what is called as a hypertensive phase. And that hypertensive phase is exhibited by 30%. We wrote the original paper showing that the Ahmed valve with the polypropylene plate that was the original S2, S7 model had 80% hypertensive phase. And the question was, I was trained in Boston, came down to Tampa, and the question was, how come that with the Barwalt implant, the hypertensive phase is only 30%, whereas with the Ahmed valve, it is 70%, 80%. I theorized it probably is from the biomaterial, right? Some biomaterials are more inflammatory than others. So I called all the inventors and they kindly donated their biomaterials. We did the famous rabbit studies and we showed that the polypropylene plate was attracting a lot of fibroblasts. So he changed this into the current version that you all are using, the model FP7. That was based on a research project that I did. So the reason why I point this out is all of you can make this clinical observation and don't just observe and leave it at that. You should be able to make the question, ask the question, why is it? What can I do to resolve this issue? And go to the next level. A variety of glaucoma drainage devices, but I strongly believe that beyond 200 to 250 microns per square millimeters, there's no efficacy. So I never use the 350s or 400s. I always restrict myself to 250 clear path nowadays, and that seems to be working. There are a lot of techniques, and a lot of these or either you can watch them on the Cataract Coach, or you can watch them on WooMedi. Is the new recent um, distribution method. Are you guys getting WooMedi emails? I need to tell those guys. They're restricting their emails to only European and American ophthalmologists. WuMedi is the name of the company. VUMEDI. So they're going around not only ophthalmology, but a lot of other companies, other specialties, and recording videos from talks from specialists who are giving talks in some of the major meetings. And so I agreed to do once a month a talk for them. You can punch in WuMedi and Google search Ramesh Ayyala. You should be able to see these videos in there. Two techniques that I want to show you. The bottom one, if you have a hypotony, patient with hypotony when there's a tube in there, if you want to do a DSAC, or there's hypotony simply because there is hypotony, too much drainage going on, instead of revising the entire tube, all you need to do is a 3 millimeter incision into the cornea on top of the tube, full thickness paracentesis if you like, and pull the tube out, tie it with a 30 with a tenoproline. It has to be tenoproline. You use Vicryl, etc. It will tie it shut. And tenoproline has some remarkable properties attached to it. It is that you cannot tie it completely shut. It allows some aqueous to go, but not a whole bunch of aqueous. It almost always leaves the pressure between 10 and 30, 10 and 20. Whereas if you use Vicryl, it will be completely shut down, and next day you'll have to deal with pressures of 30 or 40 or whatever. You don't want to solve one problem and create another problem for yourself, which is the major concern in the glaucoma world. And then I don't use scleral patch grafts either. Here is one of my old fellows developed this shin cannula, but you don't need the shin cannula. You can bend your 23 gauge butterfly needle and use that through a scleral tunnel. So it's a partial thickness scleral tunnel, 5 or 6 millimeters posterior limbus that you make, and using your bent 23 gauge butterfly needle, gently work yourself into the antechamber or the sulcus and place the tube in there. So here again, fibrosis is the main problem. All these devices, it doesn't matter who, the fancy valve, it does not matter how fancy these things are. Encapsulation is the reason why they fail. Fibrosis is our enemy, 50% failure rate in 3 to 5 years, especially in neovascular glaucoma patients. Neovascular glaucoma is the worst. You place the tube in, or you do a trab, which I think is a mistake, but either way, they fail. I mean, they fail so frequently, it is not even funny. And you keep operating on those sick eyes, and the retina guys nowadays don't want to do PRP. They just keep injecting, and injecting. It's a tragedy, honestly. So using our slow release model that I showed you before. This is, in this case, it's attached to the valve itself. In 2 to 3 months, it's completely dissolves and goes away. It's the same plate before and after. Here is the rabbit studies showing how there's a 60% reduction in fibrosis. And so this is a system that is going through FDA. If they clear, hopefully we'll start doing clinical trials. And here is the future, I think, for the glaucoma drainage devices. Um, so you use this at the time of surgery. You want to place this encapsulation, this LUT glass on top of the valve, but the valve itself comes with a chip. You saw the chip. It's a 1 millimeter chip that we created in our lab. That chip is, you can place it into the valve itself, and you can have real-time monitoring of the intraocular pressure. I'll fast forward this. These are rabbit eyes. So here my PhD student is holding a wand on top of the eye, and she's recording the frequency, which translates into the intraocular pressure. So eventually the goal is that we're going to have an iPhone-like device, but the patient holds it close to the eye, and it reads off the intraocular pressure. The chip can be um, transmitted, attached to the intraocular lens. And the different experiments that we're running is not available. This is the first. Now, what you saw actually was the first implant. So think about the future where there's a glaucoma drainage device which has a chip that will monitor the intraocular pressure for you, and then that has a glaucoma slow release antifibrotic system attached to the rest of the plate. Now you got a bomb on your hand. I mean, you're really going to change the way you're going to practice medicine, right? Because the patient himself or herself is going to sit in the house and read out the pressure. Now, one other thing is lacking in this entire scheme of things, which is, how do you know if the pressure that the patient has is adequate for the optic nerve damage that the patient came in with? What if the vision fields are getting worse? So there should be a vision field system that the patient should be able to access from the house. Why are we calling these patients back to our offices with a $200,000 Humphrey vision field device? Right? I'll come to that in a little while, as we end this lecture. So 2000, we went through all of this. In 2020, 2030, I think there's a lot of movement towards slow release drug delivery system. And my favorite, slit lamp procedures. Here is one of them, the Durista. Have anybody used it? You're not missing out much. Durista releases bimatoprost for 3 to 6 months. It was good when it was released, but after we realized that you just drop it, this is done at the slit lamp. You drop the little polymer into the antechamber, it goes into the angle, and releases the drug constantly. So for 6 months, the pressure is controlled. But then the question is, what after 6 months? This is a chronic long-term disease process. So this is not a good answer. They wanted us to do the second time, third time, and anytime you have a polymer sitting there floating around, what do you think is going to happen to the cornea? So, not a good solution. Here is Glauco's version of it, which is really cute. They developed a travoprost implant, what they call as iDose. And this is neat in the sense that this is my first case that I did with this particular device. So it comes out in this, you'll see, so the device comes attached to an injector. And what you want to do is to inject it firmly, as opposed to iStent. Here, you're attaching it, pass through the trabecular meshwork and the Scrump's canal to the scleral wall. So you got to press it in, which is why the view becomes a little distorted, because you really have to press it in. Once you press it in and you come out, there is your device. You don't want to touch the tip of it, because that's where the porosity exists to let the drug come out. Now, according to the company, there's enough drug there to last for 3 to 4 years. Now, that's the beginning. And you can go back and change it at the end of 3 years. Okay, so on top of that, we're placing eye stents on either side. This particular patient was on 3 drops, and the pressures were like 20/22 before we did this. And now the patient, last time I saw like 6 months ago, I did this procedure 6 months ago. Last I saw recently, pressure was like 14 on no drops. Great result for the patient, right? So but the catch here is it is $13,000 a pop. And my hospital has not been paid for the first 2 cases that I did. So they stop on me. I mean, till the insurance companies start accepting this and then start paying. So we're fighting the insurance system. Anytime there's a new product in the United States, especially this war between insurance companies and new products go on, and they decline anything that you say nowadays. They decline. The first answer they say is decline. You are no longer in control of healthcare. The damn insurance companies are in control of healthcare. But the more of the same is coming. Single prostaglandin analogs. I think we should expand these slow release drug delivery systems to include a prostaglandin with timolol and things like combination medications, and maybe longer lasting than 3 to 5 years. And that way we can hopefully win the war against glaucoma. How about slit lamp procedures? My all-time favorite. When a patient comes to me referred to me with the failed trap or whatever the reason is and high pressures, do you know what I do? Or acute glaucoma? I don't take them to the operating room. How many times do you want to operate on these poor people, especially they're old and they're sick and they're tired of going to the operating room? It costs you a bomb to go into the operating room. Every time you take these patients back to the operating room, it costs you a lot of money. So for the last 20 years, I've been practicing most of my glaucoma surgery. I can do almost everything for you at the slit lamp. The only thing that I don't do is cataract surgery at the slit lamp. I can, if the patient is tolerating enough, I can do your traps. I can pull out valves that are exposed. I can rotate the toric lenses into position. I can do a whole bunch of things. All you need to do is what Dr. Shivaredi, back when I was in SD hospital, used to be very famous about this. He used to talk to the patient. You should learn the art of talking to the patient and relaxing them. That's the anesthesia that they need, not IV sedations. You just need to explain to them, hey, you're here for 2 minutes, 3 minutes, 5 minutes. I'm going to finish it for you. And your cost is only like $400. Versus going to the operating room, which I have to schedule, and you got to take the entire day off. You need to bring in somebody along with you. And then the cost is like $3,000. Which one would you choose? And the way when you are a surgeon or training to be a surgeon, you own the room. Remember this: surgeons own the room. You walk into the damn operating room. Everybody should know the surgeon is right. Let no one second guess you. It's always good to be humble, but that humbleness comes with some, this word in Telugu, varchasu antaru chudandi. So that should emanate from your face. I mean that you are the surgeon and you know what you're doing. When you walk into the room and you tell the patient, I can fix this for you in 2 minutes at the slit lamp, they always look at you and say, go for it. I've never had a patient who refused slit lamp procedures. So I'm going to show you how I do it. The last section on my talk, and it always infection is uppermost on everybody's mind. And so in all these years, I have to tell you, I had only one patient who had infection. Oh, so these are my fellow this year finally is putting together the last 200 cases of done at the slit lamp, and she's publishing it. The results. These are the instruments that you need: a betadine prep, okay, and the lidocaine jelly. And for 5 minutes, I don't go into the room as my tech preps it, and then I start doing the procedure. And there's usually a partner that comes in at the waiting in the back, and so I start talking to them about when they got married and how they got married to distract the patient. And here are some of the manipulations that we do. Because of time, I'm showing you only a few common things that we do. But like I said, we do 21 different procedures between cornea, glaucoma, and cataracts and injections, all at the slit lamp. And they're all paid by the insurance company. Even if they don't pay, it's much easier for me to do a 2-minute procedure slit lamp than taking them to the operating room. Painful bleb. Most of you have seen a painful bleb. At the slit lamp, take your handheld cautery and apply 2 or 3 rows gently to reshape the bleb. Think about how to reshape the bleb, because the actual pathology there is the interaction between the lid and the bleb, right, trapping the air bubble. So by doing it 2 or 3 times, you will see that the patient will come back and be fine. And then how many of you have seen hypotony maculopathy with a leaking cystic blob, right? You can fix this thing at the slit lamp. Here is an example of it. The first bite goes through the temporal sclera, and then the second bite goes through the blob itself through the middle of the scleral flap, and it should come out on the nasal sclera. The third bite, reverse it back from the nasal sclera into the middle of the flap, and then the fourth and final bite goes from the scleral flap to the temporal sclera. Now you slowly tie tenonylon and 2 jeweler's forceps, Venice scissors, and a needle driver. That's all that you need. Add the slit lamp. Practice this. It's beautiful surgery. Every single patient I've done, they appreciate what you've achieved for them. Works like a charm. So when you're dragging this, you got to be careful so you don't break the needle. All you need to have is stable mind, stable hands, and a patient who listens to you. And you can perform all these surgeries. And by the way, that teno, you think it's exposed, it's not. You watch it, it gets epithelialized and gets submerged. Why did I do that? Here is the Hammett valve and encapsulation. So you go in with a bent 30 gauge needle from the nasal side, enter the capsule, start puncturing. You got to puncture the encapsulation. And then you start seeing bubbles of aqueous coming into subcontinental space. And then you keep puncturing that encapsulation. You do it by feel. At the end of it, I inject 0.05 cc's of mitomycin into the bubble, and 50% success rate at the end of 2 years. I mean, so you can't ask for more. And you always cauterize that using the handheld cautery. And this is a little trick that the same handheld cautery could be used for multiple patients. And because the heat will kill the bacteria in there. So here is a patient with, remember I told you acute glaucoma? I think that video is coming up next. Here is that same patient, 30 gauge needle. It goes in. Watch what happens to corneal edema. This is in real time. And you watch a couple of drops of aqueous going out through the needle, and you see the corneal edema goes away. Once the corneal edema goes away, it means that the pressure is down, the pain is gone. Now the patient is going to do whatever you want. How about DSEC? How many of you do DSECs in the presence of tubes, especially this particular patient had 3 tubes. Recently, I think on Cataract Coach, like last week or 2 weeks ago, they published my technique of doing DSECs in the presence of tubes. Here is another technique that I developed, which is what I call as airlock. So this is at the slit lamp that the graft got dislocated. Did you watch what I showed you there? Watch this. So this is something that I developed. This is before the tying of the tube technique that I showed you. This particular patient had 3 tubes. The question is, air bubble you inject, it's going to disappear super fast. So what you want to do is to lock that air bubble within Helon. And so to do that, you inject Helon into the hub of the needle, detach it. Now pull the plunger to get some air in the middle of Helon. Now close the needle back, put the needle back. Now you got Helon in the hub of the needle. You got air bubble followed by more Helon. Now this is an idea that I developed watching my swimming pool getting airlocked. So here it is. You can see the initial Helon come out, and then air bubble slowly coming out, followed by more Helon. You'll see more Helon coming out. Now it's going to lock in this, and it will be enough for you to there. The rest of the Helon is coming out. You see that? And so how about AK? Astigmatic keratotomy. You can do astigmatic keratotomy with a 15-degree blade right at the slit lamp. Why do we need to have those diamond blades and all those expensive stuff? You really don't need to. Here is my patient because of the trap, developed like 3 diopters of astigmatism. I'm doing AK right at the slit lamp. And the beauty of it is, I'll show you. I can actually look at the depth of my incision. See, no other system. The slit lamps are really good at giving you how to do this procedure simply because you can judge the depth of the incision. You look at that. See, I'm looking at if it is too shallow, I'm going to go back and repeat that. How about when you do these mixed procedures and there's a lot of hyphema in there? What do? One day post-op, the pressure is high, there's a lot of blood in there. Add the slit lamp again. You see this? By the way, I almost always leave an air bubble in the AC. At the end of mixed procedures, it minimizes the amount of blood. But in spite of that, if something like this happens, you can see corneal edema there, the pressure is high. Inject more air bubble. I think this was also broadcast on FRCOphth recently at some point. So here, inject more air. Now you go into a paracentesis that you normally have at the end of the surgery anyway. So use that paracentesis to drain out the blood. As you drain out, I use the jeweler's forceps for that purpose. As you drain out the blood, the air expands out, preventing more bleeding from happening. This is all right in front of you at the slit lamp. These are all live videos done at the slit lamp. You see this? Air expanded out, and it prevents recurrent bleeding, and you're done. And then a month later, you look at this. A little bit of blood there. Pressure is good. The patient is happy. Now, here is something that I think is relevant for you all. Just like Madurai, South India, Florida is also a hotbed for fungal infections. If you have an abscess anywhere else in the body, what do we normally do? You drain it. When you have an abscess sitting in the cornea, what are we doing? Subjecting the patient for drop after drop after drop for months on end. And by the time that infection is resolved, the patient has angle closure and iris bombay and cataract, and nobody checks the pressure during this 6-month-long ordeal, right? Have you ever seen a cornea guy ever check the pressure in the presence of a big corneal ulcer? Not even the other arm. So what happens? 6 months later, they do a cornea transplant in this cord cornea, and then they say, oh, by the way, the optic nerve is atrophied. There's no vision potential here. Why are we doing the same practice over and over again? I'll show you the reason why I'm showing you this is I get so disturbed when I see this kind of practice of medicine. So here is a patient with a fungal fusarium infection. 30 gauge, this is a 18 gauge needle that I stuck into the AC and I sucked it out. See what happened to the cornea? Did you watch what happened to the cornea? The cornea cleared up other than in the area of the infiltrate. Watch it again. Watch it again. Look at this. So there goes the needle. The entire cornea is all sick looking, right? I suck out that hyphema that is underneath, and then you're left with the actual infiltrate, which is right over there. The rest of the cornea cleared up, showing you that it is the corneal edema from high pressure that the hyphema is inducing. And here is another case, same situation. Here I go in with a 30 gauge needle, I guess, or 27 gauge, whatever, depends upon the viscosity of the thickness of the hyphema that is there. Now I'm going in there. I'll drain out. You watch the rest of the cornea, not the ulcer itself. See what happens to the rest of the cornea. The rest of the cornea is going to become clear. The edema goes away. It's telling you that a lot of these eyes are under high pressure. And nobody's taking care of the glaucoma. And consequently, by the time you resolve all of these issues, the patient is blind. So here is another gap area for you, especially I know in Tamil Nadu, fungal infections are a hotbed. And when I visited Madurai last year or 2 years ago, I forgot when, there's an entire research program dedicated to fungal infections. So slit lamp procedures are safe, effective, saves time and money. So practice slit lamp procedures. I'm very passionate about this. Every time I show this, I remember I showed this in one of the in All India Ophthalmology Society meetings, and there were people there yelling at me for showing this absurd surgery. I'm like, This is like the same concept that from intracaps to extracapsular cataract surgery, extracaps to phaco, people threw mud at people who were able to safely do this. This is a mindset thing. I am a Gandhian in the sense, unless I'm pushed into some reason that I have to lie to make some situation better, I almost never lie. I'm telling you, in 20 years, I had one patient who had blebitis. Now, how many times have you not seen blebitis following trabeculectomy that you did in the operating room itself, right? So, and the last piece that I want to leave you with is this. Um, is this minimally expensive diagnostics. All the diagnostics, it's okay, just ignore it, it will go by itself. Um, all the diagnostics that we are using now um, are so expensive that you're pricing out 95% of the world population from it. Have you realized that? The Humphrey Vision Field is $200,000. The IOL Master is $150,000. The intraocular lenses that the multifocal lenses, they cost you $3,000 to $5,000. The procedure, not only the lens but the actual procedure. The bottom line is this: we are outpricing 95% of the world population. We are practicing medicine for the rich and the famous. I don't think that's what Dr. V wants you to do, right? So I think your generation need to dumb down the diagnostics into minimally expensive devices. We had MIGS, minimally invasive glaucoma systems, but you need to start inventing devices that patients can use at home or so cheap that everybody on planet Earth can be able to afford it. So here is something that I devised many years ago because of Katrina. I ignored it. And here we have the ultimate result of it. Here is a smartphone-based virtual reality goggle set. So the beauty of this is it's an app that is agnostic of the phone. It doesn't matter what smartphone do you have. It plays out on every smartphone known to mankind existing in the market at this point. It is not dependent upon the brightness. We don't need to standardize brightness, by the way. That's all came from the old research. Oh, it has to be standardized. No, what you need is a device that makes the diagnosis. That's all you need. A device that makes the diagnosis and the device that shows this progression or regression or stability of the disease process, right? So throw away all these old rules that Zeiss, Humphrey Vision Fields, Goldman, all of them have done. It's in their era. Now in this era of the smartphones, every iPhone brightness is different from your Android iPhone, right? They come with different brightnesses. So all you need to do is to make it as bright as possible, open up the app, and then you start playing it out. And so once the instructions play out first, once you open the app and register yourself, and therein lies each eye. You don't need to patch the eye either. It's always test by default the right eye first, and in 3 minutes it's all done. And then you can view your results either on the app or on our website called Glaucoma, and you can it gives you all the instructions. Once you log into the Glaucoma, it tells you where to buy the $20 virtual reality goggles. You don't need to spend more than $20, which is like maybe 5,000 rupees or less than that in India. And under 10,000 rupees, you have a device now that you can either use in the office or you can use it in the home setting. A lot of my patients are already using this in the home setting. And you can see we also built algorithms there that will calculate out the way the progression of the disease process, just like your OCTs. You can see here how compared to the right eye, the left eye has got vision field loss, and you can see how this is decreased the sensitivity there, and you can see that it's being monitored, maintained. So in one glance, you can have visualization on the website, and you can tie the two together, and patients can do the test in the home setting. We just finished our 52, 54 patient study here. The averaging 3 tests is very comparable to the Humphrey, and test retest the specificity is almost 100%. Sensitivity is 91%, and specificity is 95%. That's all that you need. You really don't need. It's cheap, it's accessible, it's phone agnostic, and a lot of advantages uh, to this technique. So I just want you to know that a lot of systems need to be modified. If you want to achieve Dr. V's vision, I think you need to make diagnostics, surgery, everything cheap and accessible to common people. You just cannot keep on practicing medicine only for the rich and the famous. We need to dumb it down so we can take ophthalmology into the villages, not only in India but throughout the world, because blindness is a curse. That's uh, it's so sad to see people go blind. So anyway, with that, I want to thank Dr. Venkatesh again